Okay, let's get started. Good morning, everyone. I'm Eric Nestler. I'm director of the Friedman Brain Institute, and I want to welcome you all to today's webinar on a lovely nor'easter morning in New York City. Today's webinar focuses on advances in psychiatry. I've always said that the brain is the last frontier of modern medicine. It's the most complicated organ, the hardest one to study. It will take us longer to figure out how it functions under normal conditions and what goes wrong in disease. And within brain disorders, psychiatric conditions are the most complicated again. Yet the advances that we've made over the last decade or so in technologies that we have to study the brain and its disorders have been phenomenal. And we feel that we are at a true inflection point in psychiatry. We'll begin to see long-sought advances over the next several years. The importance cannot be overstated. A majority of the top causes of disability worldwide are psychiatric disorders. We also know that the top cause of lost productivity in the United States and around the world are psychiatric conditions. Nothing would have a more positive, greater impact on humanity than better understanding and conquering psychiatric conditions. Today, we have with us 4 experts from Mount Sinai who will be telling us about their efforts in this regard. I'll introduce them now very briefly. I'll ask each of them to give a short summary of the work that they and their colleagues are doing. I'll follow up with some questions, and then we'll turn to audience questions. And I would urge you all to enter your questions at the Q&A function at the bottom of your Zoom screen. Please just type your questions and we'll do our best to get to everyone today. Our speakers are Dr. Alex Charney, and perhaps the speakers could wave so that we could see who they are. Dr. Charney is the director of the Jeff and Lisa Blau Adolescent Consultation Center for Resilience and Treatment. Next will be Dr. Xiaoxi Gu, who is director of the Center for Computational Psychiatry. Then Dr. Scott Russo, who is director of a newly formed Brain-Body Research Center. And then we will close with Dr. Rachel Yehuda, who is director of a Center for Psychedelic, Psychotherapy, and Trauma Research. We're going to start with Dr. Charney, who will give us a brief overview of the work that he and his new center are doing along with their colleagues. Dr. Charney, take it away.
Thank you, Dr. Nestler. So I'm going to talk to you today about psychosis. Psychosis is, amongst the general population, a poorly understood condition. It's one of the most severe illnesses that affect humanity and consists of hearing things that aren't there, believing things that aren't true, having severe delusions, believing the police are following you, stuff of that nature. It's a very serious condition and afflicts a lot of people. Over the past 15 years, our understanding of the molecular basis or the genetic basis of these illnesses, these psychotic illnesses, has skyrocketed. We've developed a brand new understanding of what's happening in the genome to increase your risk for these conditions. However, for some reason that we have some understanding of, this has not been followed by new treatments or even new hypotheses for new treatments. And this is a real disconnect. And the Blau Center is going to focus on how these conditions develop. And we're going to take a three-pronged strategy. The first part of that first prong is that every patient is a research subject, assuming they consent. To date, in academic medical centers, you generally are not studying each patient that you treat as if they are a research subject. And for us to really make advances and to translate knowledge of disease into actual new treatments, we really do need to treat each patient as if they're part of a research study and proceed under that kind of a general philosophy. The second prong is clinical data science, and this means using the power of computational infrastructure at Mount Sinai to understand how treatment is being delivered to patients with psychosis across the health system, what's working, what's not, and to develop best practices for how we should be treating these patients day to day. And this is going to be done through artificial intelligence, machine learning, and other computational methods. And the last and perhaps the most challenging prong of our strategy to tackle psychosis in the Blau Center will be through experimental therapeutics. And here, what we want to do is we want to be a hub for being the first in human types of trials where you take knowledge of genetics and develop a hypothesis of a gene that you can target in order to develop a new treatment for psychosis and be the first group to test that treatment in a small population of individuals. We believe that we're well positioned to do this, given our expertise in psychosis and genetics, in psychiatry, and also in drug development. And that's the overall strategy we're going to take in order to tackle this very challenging disease. I'm happy to answer any questions or talk any more about this condition anytime.
Fantastic, Alex. Thank you. Let me just follow up with a quick question now. You mentioned how difficult it's been to make progress in understanding schizophrenia and developing better treatments. Why do you think we'll be able to do better now? I mean, why is this the time that we can, at long last, make some advances?
Well, I think the guiding principle in my mind is what I like to call pragmatic innovation, where we have now through genetics, we have a knowledge base of how this condition develops on some level. Now we need to discard the notion that we're going to, in a brief amount of time, understand from A to B how the illness develops at the molecular level. It's going to take, as we've learned, hundreds of years. But what we can do is be very pragmatic about it. We do have some knowledge, and let's use that knowledge in an innovative way to develop treatments that we think have a shot at working. They may not cure the disease. I hope they do, but let's at least try and make progress as opposed to trying to take the condition away altogether, which I think is kind of always going for the home run is not necessarily the best strategy. You got to do both.
Excellent, thank you. And we'll follow up with some additional questions in just a few moments. Great, so let me now call on Dr. Xiaoxi Gu, our next speaker for the morning. Dr. Gu.
Thank you, Dr. Nestler. Good morning, everyone. Thanks for showing up on this rainy day on Zoom. So as Eric actually just said beautifully, the human brain is undoubtedly the most complex organ we know of on this planet. So many of you are familiar with the concept of biological psychiatry, right? And we do typically think of the brain as a purely biological entity. But in fact, there's something else that you might have not previously thought about, which is the brain is also a massive data generating machine, right? Actually, we can have a way to estimate how much data a single person's brain is generating. It is massive. It is estimated to be over 150 gigabytes per person per day. And you know how much storage you have on your phone right now, right? So that's really way more than what most commercially available smartphones can handle or store. So this brings a really tough question to all of us as neuroscientists or neuropsychiatrists, which is how can we solve the mystery of the brain and eventually mental disorders if we can't deal with the amount of data generated by the brain to start with? So I will make a very long story short by just telling you that the solution is actually quite obvious. We're living in an era where computational tools are changing every aspect of our lives on a daily basis, right? That's not exaggeration, right? So, look at from the search engine in Google or Amazon, all the way to self-cleaning robots to self-driving cars. And they share something in common, which is they're all driven by computational tools. We must leverage the tools we have also to understand the brain. And that, unquote, is a no-brainer. So computational psychiatry as a new field was born under such a premise. To simply put, this is just an area where we try to quantify data and mechanisms of the brain and the mind, and importantly, how their breakdown might lead to mental health conditions. So this actually represents a completely new mindset and revolution to psychiatry research. And I'm very, very glad and very proud to share with you that we have a brand new center for computational psychiatry right here, right now at Mount Sinai. We are actually the first truly integrated center of such kind in the entire world, where we put data scientists, computer scientists, neuroscientists, and importantly, practicing psychiatrists together, work side by side to solve problems on a daily basis. So we have many exciting projects going on in the center right now, all the way from using AI to facilitate conventional therapies that you know of, such as psychotherapy, and see how we can improve that, all the way to using brain imaging markers as predictive biomarkers for diagnosis and treatment. And finally, to also use what we know about AI and machine learning to make better measurements directly from the brain at a single cell and a single molecule level. So all of these are sort of amazing breakthroughs that we have just been able to sort of achieve in the past couple of years. But this brings another really important point, which is by using a very data-driven and unbiased way, we are seeing beyond the traditional definition and artificial division between may seemingly different disorders, such as addiction, depression, autism, or eating disorders, because fundamentally they share a lot in common at the brain level and the data level. So I'll leave it here, and just to end with the following, that we are very ready to take our knowledge, our expertise, and importantly, our ambition and passion for mental health research to the next level. Thank you.
Thank you, Xiaoxi. It's remarkable when you think about the human brain. We know that computers are faster, can do more calculations more accurately, but the human brain is still the most powerful computational entity of which we know, and can surpass a computer in planning, abstract thinking, emotional intuition, just looking at a person's eyes and knowing how they're feeling. In what way can computational psychiatry affect the lives of our patients today? I know that the research holds tremendous promise, but what are your thoughts about how your new approach can affect positively individuals with a psychiatric disorder now?
Absolutely. So this is something we're thinking about on a daily basis, and something we can even call pragmatic computational psychiatry, right?
Mm-hmm.
Just move even beyond sort of the mechanistic part.
Yeah.
And I think the first example I gave is exactly in that direction. So right now we are actually recording real psychotherapy sessions between a psychiatrist and a patient, and track them over time and also across different pairs to see what language markers are the best predictors for long-term outcome. So just think about that. And one thing we found was very interesting, which is the more the therapist says I, the worse it is for the pair, for the treatment relationship and outcome. So there are a couple of very pragmatic markers we find that we can immediately take that into training, into education. Yeah.
Mm-hmm. Very interesting. Thank you. Okay, let's move on to our next panelist, Dr. Scott Russo. Scott?
Thank you, Dr. Nestler. It's a real pleasure to be here. I'm very honored and excited to be leading the newly launched Brain and Body Research Center, which I'll refer to throughout as the BBRC. So I just wanted to kind of set up a scenario for you all. I'm sure you've experienced a very stressful period in your life, and maybe got a cold, or maybe you felt sad and lethargic when you were sick with the flu. And it turns out this isn't really just in your head. In fact, the brain and the body are highly interconnected systems that can greatly affect one another. To better understand these so-called brain-body connections, the BBRC brings together clinical and basic researchers across multiple disciplines to really understand and get at this relationship between one's physical and mental health. So our overall strategy is bidirectional. This means that we perform trials in patients to identify disease mechanisms, and then use other model systems to really dissect the complex ways in which the brain and body interact in both health and disease. We then bring this insight back to patients, where we perform cutting-edge clinical trials for the development of novel treatments. And our ultimate goal is to improve the quality of life for people affected by brain and body stressors. So I'd like to describe just two initiatives that are ongoing at the BBRC. The first is related to studies our members are performing to understand how stress reduction strategies can promote cardiovascular health and what the biology is that drives that promotion of cardiovascular health. It turns out that when we experience chronic forms of psychological stressors, this can increase the production of immune cells that then circulate throughout the bloodstream. These immune cells contribute to chronic pathology such as atherosclerosis, which is the leading cause of heart attack and stroke worldwide. Work in the center has discovered that the mental perception of stress alone in the brain can activate these immune cells and enhance cardiovascular risk. Thus, we are employing cutting-edge strategies to inhibit these stress perception centers directly in the brain to determine whether this alone can reduce cardiovascular risk factor or risk alone. We are also working on strategies to heal the body in order to treat depression. So when that same stress that enhances the immune system to increase or promote cardiovascular risk, well, it also increases the immune cell's ability to produce these inflammatory molecules called interleukins. These interleukins can circulate throughout the bloodstream. They can then enter the brain of highly stressed or depressed individuals and cause directly an emotional disturbance. We at the BBRC are performing groundbreaking research to treat depression with drugs that block these inflammatory interleukins from even entering the brain. If successful, this would represent one of the first biologically distinct classes of antidepressant therapeutics in decades. So that's it for me. Thank you so much for your attention, and I'll turn it back over to you, Eric.
Thank you, Scott. You know, you and I have talked a lot over the years about, and here at Mount Sinai with many of our other faculty, about the flip side of the coin of stress susceptibility, and that's resilience. And I would imagine that another focus of your center would be to look for ways in which the brain and body interact with one another to boost an individual's resilience. Can you say something about that, please?
Absolutely. You know, one of the most well-known antidepressant therapeutic strategies that one can engage in life is being physically active, engaging in daily exercise. It's really thought that that exercise is targeting peripheral systems, and it's reducing, say, inflammatory molecules from being produced, a large amount of which come from fat stores in the body. And what it ultimately does is it promotes more resilient responses to stress, better coping strategies to stress. And the idea is that it's doing so by producing an anti-inflammatory state in the body.
Excellent, thank you. And we'll come back to that in a few minutes. Okay, so our final panelist will be Dr. Rachel Yehuda, telling us about her innovative work. Rachel, take it away.
Oh, thank you very much, Dr. Nestler, and thank you all for being here. I'd like to talk for a minute about trauma and PTSD. Trauma affects virtually all of us, and more than 10% of the population has PTSD at any given time. Now, conventional treatments provide some relief for PTSD symptoms, but most people who come to treatment with PTSD continue to have PTSD even after receiving medicine and psychotherapy. Our plan is to revolutionize the treatment of trauma and PTSD with psychedelic-assisted psychotherapy. And that means using medicines like MDMA or ecstasy and psilocybin, which you might know as magic mushrooms, as a way of delving into deeper material about how trauma affected one's life. And this is, of course, a radically new approach. But when taken under the right therapeutic conditions, psychedelics put people in an ideal state of self-acceptance and self-compassion and insight. Psychedelics remove the natural fear of examining an event so that the event could be looked at differently and processed and ultimately accepted. Now, almost always the trauma survivor achieves a new perspective about what happened. And this not only reduces symptoms, but often leads to personal transformation, and post-traumatic growth can be one of the most significant life experiences that a person has, according to recent studies. Now, the psychedelic is only taken a few times in the course of therapy, but the gains are great and they seem to be sustained. For example, recent data from an MDMA-assisted psychotherapy trial showed that 75% no longer had PTSD after 3 dosing sessions. But we need to build more clinical trials, and we need to reach a broader range of patients, including those in very traditional healthcare settings, like the VA, for example. And we need to reach people with intergenerational trauma and racial trauma. We need to train therapists to work with psychedelic medicines, and we need to learn how these treatment works. And that's why we created the Center for Psychedelic Psychotherapy and Trauma Research. Our center has already initiated a clinical trial at the VA with MDMA and are about to launch another one at Mount Sinai with psilocybin. We've established the first of its kind training center that will credential therapists in psychedelic psychotherapy. And we've designed state-of-the-art neuroscience studies alongside these trials. And we're uniquely positioned to lead this effort because we actually have a 30+ year track record in the biology and treatment of PTSD at Mount Sinai and at the Bronx VA. Now, we believe this center will transform the way mental health is delivered for trauma survivors. And this has never really been more important. Thank you.
Thank you, Rachel. So let me follow up and ask you about the nature of the therapy sessions with ecstasy, MDMA, or psilocybin, or another psychedelic drug. I gather that the way the drugs are given is under very carefully designed therapeutic sessions. Can you just say a little bit more what those sessions are like? In what way does the therapist work with the patient when they have one of these drugs on board?
Yes, thank you. Well, first of all, there are many sessions of preparation for this event, and we have created some really novel space for doing this therapy. The dosing sessions last for 8 hours, so the room has to be exquisitely comfortable. It's like really walking into something very serene, almost like a spa, where you're able to lie down. There's going to be music playing and eye shades, and an environment that is really perfectly conducive to a good experience. The therapists are going to really guide people through the process by being there to talk when the patient wants to talk, or letting the patient process material inwards. But it's an 8-hour session. The morning after the session, the therapist and the patient talk about what happened. It's called integration, and they do so for several sessions before the next dosing session. So this is quite unusual. It's not like anything that we've ever done in psychiatry, but it seems to really be something that is working.
Mm-hmm. Very interesting. Thank you. So let me go back now and ask a few questions of my own, and then we'll begin to weave some of the audience questions in as well. Please feel free to put your questions in the Q&A function at the bottom of your Zoom screens. Dr. Charney, let me go back to you and the Blau Center. And I do want to take this as an opportunity to thank Lisa and Jeff Blau for their recent very generous gift to Mount Sinai to create this center. One of our audience members, Deirdre Miller, is asking whether the center will focus on adults or also include teenagers.
Both. So the illness of schizophrenia, the process that is causing the disease, as far as we know, begins before the actual symptoms start. So if a patient, the presenting symptoms that usually alert the doctors that this is schizophrenia, or the patient is hearing voices that aren't there. Now, the process that ultimately causes that illness begins before the symptoms actually start themselves. So it is critical to study individuals before the symptoms themselves begin. But you could imagine how challenging this is because there's no clear way to know who's going to get the disease before the symptoms start. So it's kind of this circular challenge of when to start studying the illness, and then if you're going to, the earlier you go, then it comes which patients are you actually study, because you don't know who's going to get the disease. But the short answer is it's critical to study both the individuals who don't have it yet, so you could develop treatments to prevent it from occurring. But we also can't forget about the people who have the disease. They're suffering immensely, and the research needs to also be targeted to develop treatments that will help them.
Mm-hmm. And while I have you, we just have a question in Q&A from Jen Hamlin, who asks, what advances in diagnosis have been made in the past few decades for schizophrenia. And I wonder if this would be a good opportunity for you to also talk about your other role at Mount Sinai, co-directing the Mount Sinai Clinical Intelligence Center, where you've used electronic health record data in individuals diagnosed with schizophrenia as a way to gain some additional insight into diagnosis and treatment. So maybe you can answer Jen's question, but also talk more broadly about the use of big patient data, which we call clinical intelligence, to help us deal with schizophrenia.
Yeah, absolutely. This is a great question. The answer is pretty easy. There hasn't been any improvement in diagnosis of schizophrenia over the last few decades. The definition of schizophrenia, as it appears in this book that psychiatrists use as like a Bible, it's called the DSM. The definition of the illness is sort of arbitrary. So the diagnosis is based on this criteria that doesn't necessarily have a basis in the ground truth understanding of how the disease occurs. So the way we diagnose it hasn't really changed in a meaningful way over many years. The work Eric referred to, the clinical intelligence, this kind of gets at how could you start? Okay, so I'm criticizing the DSM in some ways. Well, how could we do better? Well, one way is you can imagine genetics could help us. Is there any way we could use genetics paired with the clinical presentation of a person in the real world to kind of predict who's going to get the disease, or amongst people who have the disease, who's going to do okay and who's not. So a lot of the work that we're doing these days is to put all these data streams together in a big health system like Mount Sinai, to see if we could develop models that will help us predict those things using high performance computing. The work to date has not done that. I mean, it's a tough problem. There's definitely evidence that we could do better in making these types of predictions about who's going to get the disease and how people who have it are going to fare. But the truth is, it's a totally kind of unexplored area. You'd be surprised. You'd think that in a big health system that's invested immense amounts in data science, like Sinai has, much more than the average academic center, you'd think that we would have a very strong grasp of who's being treated in what way and what's working and what's not through our data. But this is an underappreciated data engineering challenge that we're now confronting really for the first time in a serious way about how to approach this issue to get a better grasp on what's actually going on throughout a big complex health system like Sinai.
Mm-hmm. Yeah, and what you're saying really underscores the extent to which our use of artificial intelligence and machine learning with the vast data sets that we're generating are really just at the beginning, earliest stages of being now exploited or mined for advances in diagnosis and treatment. So it is very interesting. And it brings me back to Dr. Gu's efforts, also using big data approaches. Dr. Gu, we have a question from the audience. Yvette Fromer is asking whether your research program has been evaluating drug resistance for patients with depression. In other words, are you looking at evidence of why some patients don't respond well to existing treatments for depression? And it reminds me of projects that you have underway with the Nash Family Center for Advanced Circuit Therapeutics, Dr. Helen Mayberg and colleagues at Mount Sinai West. Might be a good way for you to talk about some of the efforts that you and others are using to understand treatment of depression.
Yeah, exactly. Thank you for the question. And by the way, I think the audience somehow have a way about knowing some planned projects already. This speaks to, I think, really the significance of this question, right? So yes, we are about to launch a study where we will, again, try to collect a few different objective brain-generated data types in what's called treatment-resistant depression. So these are patients that have, pretty much failed, do not respond to any conventional medication. But I think in the bigger context, this is really something that we're working towards, something I would term as computational therapeutics, because right now, we all know that, if you go to see a psychiatrist or a psychologist, you might be giving one therapy over another, you might be giving one medication over another, but it's almost purely based on experience and guess and a subjective evaluation, right? But imagine a day when you can walk into the office, you might be, taking a few brain scans, we might still take your subjective reports, all the clinical information, demographics that Alex described. But again, importantly, biological information, right, from your brain, and put that into a AI algorithm, and it actually can predict which treatment you might respond the best to, right? And actually, this sounds like sci-fi, but it's not really that far away from us, because there's currently, several large scale studies already going on similar to this one. But yes, thank you for this question. We are definitely working on it.
And I think a good follow-up of that question would be some of the work that Dr. Russo and others are doing in the Brain Body Research Center, where the effort has been to try to identify different subtypes of depression. I think back to when I did my psychiatry training 35 years ago. The only way we made a diagnosis in psychiatry is to talk to patients and their families about the symptoms they have. Dr. Charney was alluding to this just a few moments ago, that in his training, much more recently, it was basically the same thing. But in every other branch of medicine, a patient goes to a doctor and the doctor does a series of tests. We can imagine one day a person with an emotional problem going to a doctor, getting a brain scan, a blood test, a genetic test, a whole series of measures to determine what subtype of depression or schizophrenia or another disorder they might have, which would then guide us toward better treatment. So Scott, tell us a bit more about the many ways in which we can use data from other organs to inform about depression. You talked about immune measures, so-called cytokines, hormones, immune-related cytokines, immune-related hormones in the bloodstream called cytokines. But what other kinds of measures are you and others at Mount Sinai using to understand subtypes of depression, and then how you can attack those with specified treatments?
It's a great question. And so, this is all done in collaboration between the BBRC and the Depression and Anxiety Center for Discovery with Dr. James Murrow. Effectively, what our labs do is we've coordinated an intake strategy such that every patient that comes into our clinics at Mount Sinai are diagnosed for their whatever psychiatric condition. In the case of depression, they're determined to have bona fide depression based upon the DSM. We then take a blood sample from those patients. They go on to do functional imaging with our Imaging Institute. We get as many clinical identifiers as possible. And what our data shows is that there is an extreme degree of heterogeneity amongst all of these biological readouts that we get in our patient cohort. So you mentioned this kind of immune-based disturbance. We think that's a biotype of depression that represents roughly 25% of the overall population. They are also the most chronically ill and treatment resistant. So it's a patient cohort that we focus extensively on because of the risk and the fact that there really are no other treatments for that subtype. But there's a whole host of other biological features and factors that are coming up in our large data sets that suggest there's many layers and many subtypes to depression, and probably to all psychiatric syndromes.
And just another whole dimension that we haven't talked about is the gut microbiome. So we know that our guts contain roughly the same number of bacterial cells of the total number of human cells that make up our body, just an astounding statistic. And we know that there are wide variations in the numbers and types of bacteria that each of us have in our guts, which are in turn heavily influenced by the foods we eat. What are your thoughts about the gut microbiome and psychiatry?
It's a new frontier. I think you mentioned that the brain is the kind of the last frontier, and I would argue that we still have this complex interface between body organ systems and the brain that will span well beyond our understanding of the brain itself. But it's very well established that the gut microbiome is impacted in people with depression, and in fact, there's been studies to suggest that fecal implants or fecal material that's transplanted from a healthy individual to depressed individual has.
I mean, just to make this graphic, this is taking a fecal sample, someone's stool, processing it, cleaning it up, but then feeding it as bacteria back to another individual.
Exactly, and it has shown to be effective in depression treatment. But I think it also goes beyond depression. So we've got partners in our center that are studying brain bowel connections, right? And so it's also very likely that these same mechanisms are leading to other symptoms, maybe more reflective of irritable bowel syndrome. And so it's this really vicious cycle where I think we don't know what's causing it, but there's a connection between the brain and the body back up to the brain, and multiple physical illnesses can result from this, as well as mental disturbances.
Mm-hmm. Thank you. Rachel, let's go back to you. Claudia in the audience is asking how trauma is defined. And also, once you expand upon the definition of trauma, whether you can also talk about whether similar approaches, ecstasy or psilocybin or related molecules, might be used to treat depression and anxiety disorders as well.
Yeah, thank you for that question. So a trauma, I like to define it as a watershed event that kind of divides your life into a before and after, and really makes you feel subjectively like you're not the same person you were before. That's more of an artistic definition. The way that the DSM-5 defines a trauma is an event that really causes a threat to one's life or physical integrity. And they mean things like interpersonal violence or combat, or really even experiencing loss, events that really engender this kind of fear, helplessness, or horror. But I think that, the subjective definition of really feeling transformed in a negative way is also a very powerful definition for that. In terms of using these psychedelic treatments for depression and anxiety, yes, we're going to be exploring that. We're starting out with trauma and PTSD, but as you've heard already from the other my other colleagues, these conditions can be very related, right? The brain is complicated, and a lot of people that have trauma develop depression and maybe not PTSD, or develop a little of both, or also develop anxiety. It's not, the DSM, which is the diagnostic manual, isn't really that specific, and we all recognize that there's overlap in diagnosis and in treatment. The idea of the psychedelic therapies is doesn't really matter the diagnosis, and I'll just be very honest about that. What's being offered with psychedelic psychotherapy is a way to go deeper, is a way to look at something from a different perspective while you're in a state that you don't normally get to, which is trusting, relaxed, non-judgmental about yourself, kind of not full of self-blame. A lot of people with trauma think a lot of aspects of what happened to them were their fault. And it's very difficult to get out of that mindset. It kind of creates this immutable narrative of, I brought this on myself. I didn't behave the way I should have behaved. I deserve to feel this way. And you can go to therapy, but if you can't change this internal state, you're just talking words. And medicines really don't address that way that you feel about yourself. What an antidepressant will do is it will suppress temporarily, as long as you're taking the medication, those symptoms that pop up when you're feeling so guilty and when you're feeling all these things that many people feel after trauma. So it's an opportunity to just kind of break through that and develop a little compassion for yourself, see things in a new way, understand that maybe you were young, or there was a war, or you couldn't do anything about it, which seems obvious in a different state, but may not be obvious when you're kind of when your brain is kind of colluding to really give you a different picture of yourself. So yes, we really hope to generalize this. We're just starting with trauma and PTSD.
Yep, no, and I certainly agree with you. I always think of depression, anxiety, and post-traumatic stress disorders being stress-related illnesses that are highly related to one another. So if I'm understanding what you're saying correctly, and I think it's quite interesting, is that a drug like ecstasy or psychedelic might be helping by unsticking a way that a person is thinking about things or the way they experience or understand things in their lives. It just creates the opportunity to imagine things in a different way. Am I getting that right?
Yeah, I think you are getting that right. Imagine you're a scientist. Imagine if you didn't have tools like a microscope to see something in the brain that you couldn't see with your naked eye, or if you were an astronomer and you didn't have a telescope. You're limited. Psychedelics aren't a therapy per se, they're a tool. They're a tool to go deeper into consciousness and see something that you can't quite see, but once you see it, you don't have to keep seeing it. Once you see something under the microscope, you go and write your paper and you work with it and you say, what does that mean? And the very same thing is true when you have a psychedelic journey. The hard work becomes afterwards when you do the integration and you talk about what it all means. What insight did you learn? The one that that really made an impression on me was a woman who had been abused in childhood who came to the simplest realization. And that was how small she was at age 5 when her stepfather abused her. And here she had been feeling like she was an equal because you know why? The stepfather would say, if you tell anyone, the whole world will explode and mommy will hate you. So he's giving her the message that she's so powerful and everything rests on her poor little 5-year-old shoulders. And in a psychedelic journey, she finally was able to understand in a whole different way that a 5-year-old doesn't have that kind of power. And in fact, her power was being taken away and none of it was her fault. So it's simple, but it's profound.
Yeah, no, excellent. Thank you. You mentioned the words microscope and telescope, and that actually reminded me of some of the tools that Xiaoxi uses to study the brain imaging, which is the tool that we have available to understand how the brain is functioning in our patients. Xiaoxi, give us an idea of the range of approaches that you're using in brain imaging, which I think is some of the primary data you have that's deriving these terabytes of information of how the brain functions.
Yes, exactly. So brain imaging, take it at face value, is really imaging the brain. So it's like take pictures of the brain, right? That's the simplest way. So we have something what's called structural imaging, which really means just take a picture of the structure. So, and there's a lot of work in trying to figure out if there are visible structural deficits in the brain related to, different mental disorders. But more importantly, we have something what's called functional MRI, right? And that means we're actually measuring the activities of the brain as the individual is, thinking about something, for example. It could be thinking about the trauma, right? It could be, actually receiving therapy or actually listening to therapist's voice in the scanner. There was actually just a new paper came out, was very interesting and profound. And it could be, retrieving perhaps a past memory, right? So we actually have subjects usually, do something, thinking about something, feeling about something, and then see how their brain responds to that sort of in real time. And what's really interesting now is that there's something called real-time feedback, meaning that we can then visualize to the subject, to the individual, what your brain activity is like at the moment. And then we can train you, right, using mindfulness or cognitive, strategies to either up or down regulate that brain activity. So thinking about sort of, again, practicing mindfulness with something showing your current heart rate or respiration rate. So there's a vast majority of tools available right now. We also can measure electrical activities of the brain directly using something called EEG, right? Yeah.
Okay, thank you very much. Okay, so now in the remaining few minutes that we have today, let's focus on new treatments. And Alex, I'm going to turn to you first to tell us about whether you have ideas already about possible experimental drugs that you might use to help people with schizophrenia, and also whether you're considering non-drug approaches, perhaps some type of electrical or magnetic stimulation techniques that might be available.
Yeah, absolutely. So I think there's a couple different approaches that we should take. So one is optimizing the use of treatments that exist. So this means doing these types of large multi-center trials of the drugs that are already on the market to see if we could just use them in a more optimal way. There's 60 different types of antipsychotics, or some better than others. This is a constant. As more drugs come on the market, these drugs are very similar, but there's always a need to know which are the best to use to keep the best current best practices up to date. So that's one angle. Not necessarily the most kind of innovative or exciting, but something that's very important to do. On the more kind of novel treatment strategies, there are several targets that we think are extremely promising. My favorite is the NMDA receptor subunit GRIN2A. This is a gene that has been implicated in psychosis through multiple different types of genetic studies from very large populations. So it's very robustly associated with the disease. It's also a target that we know when you upregulate the activity of this receptor, healthy people will become psychotic. This is a receptor that's acted on by drugs like ketamine and PCP that at high doses cause symptoms that look very similar to psychosis, that are psychosis. So we know this receptor, it's implicated through genetics, that if you target it in a person, you push it up or push it down, it has the effects you would expect. So this is a very promising target for the condition. The challenge is that there aren't great drugs that act on this receptor in the direction we need it to treat the illness. Most of the drugs like ketamine are acting in the opposite direction. We need a drug that does the opposite of ketamine, essentially. There aren't drugs like this that are routinely given to human beings that we know are safe and could just be thrown into a clinical trial right away. So there's some work to do to determine what the actual molecule needs to be. But this is going to be one of our top priorities moving forward. And lastly, yeah, absolutely. There are non-pharmacological interventions that people have are now exploring for schizophrenia. Some of these are magnet-based. You don't need to do a surgery. It goes right on top of the scalp. The problem with these treatments is they're very frequent. You need to get the treatment like so frequently, a couple times a week. We already have a problem just getting our patients with psychosis to come into the clinic once a month. Getting them to come in every day is probably beyond the realm of what's realistic. But these treatments are being explored. And then more invasive treatments like deep brain stimulation, where you actually insert certain electrode into an individual's brain, and it stays there indefinitely and delivers a current that's therapeutic. This has been explored at a small number of places for schizophrenia. We are doing our first patient in the coming year. So this is a place we plan to pursue. These are usually very small studies, very specific types of patients who are appropriate for this type of invasive neurosurgical intervention for a psychiatric disease. But it is something that is important to do, because it not only is it potentially helpful for the patient, but it also gives you the opportunity to study the brain in a human being in a way that typically is not possible. So it's a very promising avenue, both for research and clinical purposes.
Mm-hmm. And I don't know if you or Xiaoxi wants to answer this, but I've also read a lot about computer-based therapies. So cognitive training, helping people with schizophrenia, perhaps autism, individuals suffering from dementia, Alzheimer's disease, or another type of dementia, in terms of proving the range of cognitive functions that are affected in their particular disorders. Would either of you be able to talk about these computer-based approaches?
Yeah, I can take a shot. So absolutely. So there are actually also some questions about environmental sort of impact. I think this plays into that. We know in humans in particular, even the most abstract beliefs or feelings and mental states can be represented with biological substrates. So this is exactly why actually behavior and cognition might be the ultimate powerful non-invasive tool we have in humans, right? Mm-hmm. And absolutely. So actually the biofeedback approach that I just described is in that realm. We can do that actually with, of course, more structured sort of interventions, such as, I think, like improving, right? Using computational tools, improving what psychiatrists and clinical psychologists have been doing for centuries. That I think has a huge potential there, because, if we can extract the best elements of those cognitive interventions, right? We might, one is that we can improve education and training and really deliver the most efficient treatments, cognitive treatments for patients. Two, as you said, we can essentially create a large language database, and we can discuss whether we want the patient to know or not if they're dealing with maybe artificial agent or just a computer. But there has been some initial evidence suggesting just talking to somebody, right? That person can be a person or a computer-based agent. And a lot of us are doing, Zoom or, web-based therapy anyway these days. So I think that also opens up a huge possibility for expanding access to mental health care. Mm-hmm. And of course, everything is much easier to collect and for us to quantify and eventually make individualized predictions.
Mm-hmm. Thank you.
Yeah.
And Scott, what about depression and anxiety disorders beyond the use of ecstasy and psychedelics that Rachel has talked about? You mentioned the Depression and Anxiety Center and collaborations you have with them at Mount Sinai. What are some of the treatments that people in the center and you are coming up with for individuals with these disorders?
Yeah, thank you. So we're taking two approaches. One is a repurposing approach, looking at existing drugs that are already FDA approved for something else. And so for this approach, we've identified classes of monoclonal antibodies. They're typically used to treat conditions like psoriasis or other autoimmune or inflammatory-based conditions. What we've noticed is that these treatments are both effective in reversing some of the autoimmune-like symptoms, but also they seem to have positive effects on mood. So we've identified a whole host of these interleukin targets, and we're testing monoclonal antibody strategies that would bind to these peripheral inflammatory molecules, neutralize them, sequester them in the periphery, and prevent them from ever acting on the brain to see whether or not they're antidepressant. The other strategy is more discovery-based, and this is from targets that we're identifying in large-scale analysis of our patients that I described to one of your earlier questions. We've identified a couple of interesting targets that seem to be shared amongst conditions like heart disease and depression, for example. And what we think that these targets will be effective we think what would be an effective way to target these shared mechanisms is again with these monoclonal strategies, but this would require new drugs. We'd have to work closely with drug discovery here at Sinai and make these new drugs, since no currently available drugs exist to target them. And the thing that we're most excited about is, as I mentioned in my brief blurb earlier on, that stress seems to cause this enhancement in the immune system, just kind of generally speaking. And it's marked by an increase in the production of these inflammatory immune cells that you can detect in the blood. Well, we think that those inflammatory immune cells will travel to cardiovascular plaques and increase progression and rupture, but they'll also travel to the brain. So one of our targets would be designed to prevent those cells from targeting or honing into those tissue compartments, thereby maybe having a dual medication to reduce depression risk, but also cardiovascular risk.
Mm-hmm. Yep, very good. Okay, so we're almost at the end of the hour, and there's a question in chat that I thought would be a good way to end the session. This is from Deirdre Miller, and the question is, what about the role of environmental factors on mental health, such as structural racism, poverty, exposure to lead paint, other toxins, lack of access to quality food, etc. Is this part of the clinical data that are being collected and used to inform any aspect of our work in psychiatry? This may be something that all four of you will want to comment on. I would just ask you to do so briefly, given the short time left in the hour. And whoever wants to speak first, please go ahead and do so to address these extremely important considerations.
I'll go first.
Go ahead,
Eric.
Rachel.
I think those are really some of the most relevant factors in mental health, even in psychosis. I think that even if we identify genes and we identify how brain networks work, what we have to understand is that the environment affects how those genes function, and the environment affects how the brain works in large measure. So when people have impoverished environments, and when people are exposed to toxins or lack of good quality food, this is absolutely going to be an important factor. So it's ironic that the conditions like PTSD that we think are completely environmental might have a little bit of a genetic component,
Sure.
and some of the disorders that we think are completely genetic clearly are not completely genetic. They might highly be influenced by genes, but it is about better environments. The reason that's so important is that we can probably do something about environments.
Mm-hmm. Excellent. Does anybody else want to say something? Alex, go ahead, and I'll give you the last word because we are at the end of the hour.
Yeah, I just want to emphasize one point on this question, and that's there's no doubt, right? Of course, the environment has an immense impact on mental health, and genetics versus environment. This is the age-old debate. We're not going to solve it in this hour, but in the real world of clinical practice, we do not collect data in the right way to be able to appropriately understand the contribution of different environmental factors, right? And this is a central problem, not just in psychiatry, but in medicine in general, which is that for the millions of patients we're treating every day, the doctors and nurses and clinicians are asking them about their environment, and they're learning a lot, but it's not being recorded in a structured way, so we can't learn anything about it. And this is a total missed opportunity. And really, it could be changed pretty easily, but we do need to make an emphasis to do so and put resources into it. So if we want to properly answer this question about the different forces at play in mental health in the real world, we do need to start changing the way we're collecting information at the point of care. And this is a critical point.
Yeah, so that's a great point, and it really underscores what we've known historically, is that there have been big differences in the way individuals are first diagnosed and then treated based on social, racial, cultural, and economic factors. And we're working hard. We have learned more about them, and we're working hard to do better. So with that, we are at the end of the hour. I do want to thank you all again very much for joining us. I hope you've enjoyed listening to the advances that are being made in psychiatry. As I said at the outset, I don't think anything is more important for humanity than better understanding and treating mental illness. Nearly every family is affected by it, and mental illness continues to have too much of a devastating impact on our lives, of course, underscored by our recent experience with the COVID-19 pandemic. Now that we're getting a better handle on the virus, we're beginning to see more and more of the long-term emotional consequences of the social and economic deprivation that the virus caused. We're going to have to redouble our efforts in treating psychiatry. All of the work that you've talked about today requires the generosity of our donors, and I would once again like you to please consider a gift to the Friedman Brain Institute to support these efforts. We'll put the flow code back on the screen and leave it up for the remaining minute. But thank you again very much for joining us. Have a good day. Bye-bye.